Raja Flores gave a very good statement that introduced I-ELCART, and I'm going to show you some of our preliminary results along that way. So we started it in 2016. Let's see. Sorry, this one is. So these are our participants. So our focus is we want to have multi-institutional prospective enrollment. And we thank all the contributors to our database. We have the procedure that's outlined in the publications of what we collect, and you'll hear various talks. We have a first book that describes, number one, the history of surgical treatment by Fred Granis, but it gives our preliminary results that caused us to start I-ELCART. And we have book number 2 in process. We have a management system that we provide for this purpose. And as very elegantly just stated, we want to maximize the benefit of screening because we need to, and to do that, we need to optimize the treatment and we need to understand all of the various components, including quality of life measures and so on. So that's our work. And I just want to put a perspective on this. Pneumonectomy was introduced somewhere in the turn of the century, but it took 60 years really until 1962 to look at lobectomy versus pneumonectomy, which was the standard of care at that time. And that was based on 2 prospective cohorts, one from the Ochsner Clinic and one from the Overholt Clinic, that showed that pneumonectomy was not superior to lobectomy. And it still took 60 years later to provide the results of the Nasser al-Turki randomized trials that said there was equivalency between sublobar resection and lobectomy. But 9 years earlier, we had shown that, actually Nasser al-Turki had shown in a publication from I-ELCART or I-ELCAP that these were equivalent. So I want to stress that prospectively collected cohort studies are very important, as had been called for by the Institute of Medicine in the US. So I want to briefly discuss the results of our surgery versus SBRT. And if you look at the literature that was quoted earlier today, many of those cases are larger. So we wanted to focus on small lung cancers, 20 millimeters or smaller in maximum diameter, because I think that's an important comparison in the context of screening. So we have almost 1,115 cases, mainly of surgery, so we want to get more SBRT collections, but we included I-ELCAP because we had much longer term follow-up, and I always heard from the surgeon there's no 5-year follow-up, but this is longer term follow-up. And we have the I-ELCART, which has the more modern also SBRT. This shows the standard comparison by age and of the 2 cohorts, SBRT surgery versus SBRT. In general, the surgical patients were younger. They were more frequently white and had fewer comorbidities, particularly cardiac abnormalities, vascular abnormalities, COPD, diabetes, and other diseases. And if you compared those that had none or one comorbidity, 55% of the surgical patients fell in that category, only 19% of the SBRT patients. And that's the current selection criteria. Overall, the maximum tumor diameter for the surgical patients was smaller. The distance, they were more peripherally located, more frequently adenocarcinomas, and less frequently squamous cell carcinomas. And the median follow-up time for both was 59 months for the surgery and 49 months for the SBRT. So when you look at the lung cancer specific survival separately by the treatments, surgery and SBRT were equivalent. both in 5 years, because we only have 5-year follow-up in I-ELCART, but also 10 years, there was no statistically significant difference, and the curves overlap. When you look at the all-cause in the two, and we separated them for IELCART because there's shorter follow-up time from the I-ELCAP surgery versus radiotherapy, and there clearly is a statistical difference. And so we looked at the hazard ratio for when you have 1-to-1 matching, propensity score matching for both. There are no significant differences in the lung cancer specific mortality, but we clearly already saw that. But what is it for the all-cause? For all-cause, we looked at the combined, and even unadjusted all-cause was statistically significantly different. But if you look at the p-value for the adjusted, there's no significant difference for the combined cohort, for the I-ELCAP cohort, or for the I-ELCART cohort. And then you want to also see how well did you do the matching, and this mean standardized difference is given here and shows that there's very good matching. So in conclusion, from these two prospectively collected cohorts, and I say that that's the important thing, prospectively collected is better than retrospectively collected. So prospectively, if you enroll individuals and you focus on cancers 20 millimeters or less in maximum diameter, there's no significant difference in the lung cancer specific or in the all-cause survival after balancing for covariates of age and comorbidities using propensity matching. But I want to point out that survival of solid and subsolid non-small cell cancers are significantly different. And in both the randomized trials and in other studies, these were not separate, and they need to be reported separately because whether all-cause or lung cancer specific, there's a significant difference between solid tumors and non-solid tumors. And when you have unequal matching in any report, you can't really tease them apart. So we need to, as I say, keep rethinking and optimizing all components, and that's what you're going to hear about today. And hopefully that will make lung cancer survival after screening even better. So we thank all the contributors for the talks this morning. Thank you very much.